Assalamu alaikum. The short clinical day. First scenario, you have male patient, 40 years old, present with abdominal discomfort. Please proceed and examine the patient. Yeah, here you go, Dr. Tanvir.
Okay. So first I will enter the room. I will give the greetings to the examiner. Hello, sir. Hello, sir. Then I will wash my hand. I will go to the near to the patient. Hello, sir. I am Dr. Ali, one of the doctor in the tummy clinic today. I have been asked to examine your tummy. Is it okay for you?
Okay, doctor.
If you feel any pain or discomfort during my examination, please let me know.
Okay.
So first of all, I will make a general look of the patient, yeah, to see is there any visible pallor or jaundice in the face. Then I will remove the shirt from the up to the chest and the downside up to the inguinal area, and to make in the supine position. And then I will ask, I'll see that any hand wasting, any visible needle prick, or any visible fistula, or any chest catheter mark, or anything chest like a spider navy, or any gynecomastia, any abdomen distended, umbilical position, any caput medusa, any visible mass, or any, then I need to go to the near to the bedding. I need to see any visible swelling or deformity in the leg or not. Then I'll see beside the bed, is there anything, bedside equipment, anything like any catheter or any other things. I'll make sure. Then I will make little elevate the raise of the head, and I'll tell from the bed. I will tell, sir, can you make a cuff to see by cuffing is there any visible swelling in the tummy or in the inguinal area. Then I will make the flat in the patient. Then I will come to the bed.
Doctor, please, يعني, can you step by step? I will tell you the finding.
Please give him yes some finding from the hand.
Oh,
Okay.
Okay.
now you
What I
examine the
said,
hand.
what I said, just tell me what I found till now.
By general looking, no finding. Now you examine the hand. Oh,
Okay.
tell me what you
When I
will
will
examine the
start,
hand.
yes. When I will start after that, you will tell. Like till now, there is nothing positive, is it?
Yes, tell now.
Okay. Then I will go to the near to the hand, and I already washed my hand. Now I will make warm my hand. And I will say,
Okay.
sir, can you make rest your hand, please? So I need to see any tremor or not. Then I need to check
No
by
tremors.
kneel down. Okay, then by bending of my knee, I need to check any clubbing, any splinter hemorrhage, any polyonychia or leukonychia. Then I need to make the hand supine position. I need to check is there any palmary edema, any feature of the pallor or jaundice in the hand or not. And
Hand is
or
normal. Until now, hand is
okay,
normal.
till now everything normal. Okay,
Till
then
now,
I
listen, still.
okay. Then I need to go for pulse examination. Is there any abnormal pulse or something like low volume, high volume, or AF type, any irregularity? Then I need to see the hand. Is there any feature of the steroid purpura or any feature of the needle prick, or there is a diabetic needle prick, or any tattoo mark in the hand or not? Any
Uh,
AV fistula?
no fistula, but you find at the elbow there's nodules, bilateral nodules.
Bilateral nodules in the elbow and
Yes,
antecubital area.
in elbow, in extensor side.
Extensor side. Okay, so
Yes.
if I found that elbow, there is a nodule. Is it hard or soft?
Um, sorry.
Like is it heavy fistula or not?
No fistula, no fistula.
No fistula, but hard. There is a. Is it tender?
Not tender.
Not tender, just hard nodule both elbow side. Okay, but
Mm.
there is a no joint deformity in the head, is it?
No, no deformity. You didn't
Okay,
found the deformity, but nodules.
nodules. Okay, then I need to go. Sir, I will press over your tummy. If you don't mind, can you see that side? to check any hepatojugular reflex and JBP, any raised JBP or any hepatojugular reflex. Then
No.
then I need to go for the face. Is the face any parotid swelling, any facial rash, anything or not? Then I need to go for checking the eyes for anemia and jaundice. Then I need to go for the mouth of examination. Is there any ulceration? Then I need to go for chest examination, any visible scar mark or spider nevus, gynecomastia, anything or not. Then I need to go for tummy. Is there any tummy distension or not, and any umbilical position? I need to see. Then I need to again warm my hand, and I need to, sir, I will touch your tummy. So superficial palpation and deep palpation from 9 quadrant, I will check. Is there any palpable mass or something, or any
Uh,
abdominal distension?
uh, by superficial palpation, you check for any tenderness. Uh, mild tenderness
Yes.
in left hypochondria. Mild tenderness.
Okay. Is there organomegaly? I mean splenomegaly?
You know, will palpate for organomegaly.
Yes, like liver,
Uh,
kidney, and
yes,
any transplanted mass,
Yeah,
any
explain the steps, Dr. Tanvir, how you when from
yeah.
where
Okay,
you start.
first of all, I start 9 quadrant superficial palpation. Then in deep palpation, I found there is a left hypochondriac mass. So when there is a left hypochondriac mass, I need to palpate that. In the, what about the surface? Is there smooth, any mediastinal notch, and it's a finger going above the swelling? I mean, above swelling test I need to do.
yes,
And
doctor.
yes.
At this stage, you find a large spleen, 3
Mm.
centimeters below the costal margin, or
Mm.
enlarged mass. يعني you can say enlarged mass, 3 centimeters below costal margin, dull on percussion, and not tender, smooth surface. You can find
Okay.
not.
Okay, so I found only the splenomegaly, no hepatomegaly, no
No,
polycystic, polycystic kidney, or no renal transplant
And moving
mass,
with
is it?
yes,
respiration, right?
And moving with the respiration, yes,
Yes,
exactly.
exactly.
yes, moving
Okay.
with.
Yeah,
So
I think
only I
now
found that,
7 minutes.
okay,
Yes.
okay.
Are you
So
done
only
or any step missing?
because actually I am something using some more word, but in the exam I will not use. That's why taking
Yeah, yeah,
little
of
more
course.
time.
While
Yes,
explaining, you will take time. Okay. Now you
yes, yes.
can summarize, examine our
Then
question.
I need to auscultate in the general auscultation that bow sound and any venous harm, any like renal buoy, and I will auscultate over the spleen. Is there any splenic rub, anything there?
No,
Nothing. Okay. Then I need to go for that lymph node examination and also sacral edema and also leg edema. I would like
no,
finish my Okay, I would like finish my examination by checking the vital chart, including the blood pressure, urine for protein glucose nitrate, and I need
Okay.
to do the genital examination and rectal examination.
Okay. So you're done now. What you miss, you want to examine before ending?
Before that, I already checked that sacral edema, leg edema, lymph
No,
node.
no.
I already
Some,
checked.
yeah, lymph node. Where? Which lymph node you want to examine?
I need to say first, I need to check that cervical lymph node. If it's
Axillary.
positive,
Yeah. And that
then I will go axillary.
and the
Yes,
abdomen is axillary. And the chest, you will examine for cervical. Okay.
yes.
Time is up now. Dr. Marwa, you can start the examiner questions.
okay, present your case, doctor.
Okay, so in this gentleman, 40 years old, on examination in the supine position, I found there is a bilateral hard nodule which is non-tender in the elbow area. And also, I found there is no feature of the anemia and jaundice I could not appreciate, but I found there is a enlarged palpable organ in the left hypochondriac area, which is moving with the respiration and which is soft, firm in the consistency, and I cannot get above the swelling. And percussion, I found this is a dull and auscultation, there is a no rub. I don't found any other organomegaly like hepatomegaly or polycystic kidney feature or any transplant. I don't found any scar mark in that domain and no distension like ascites I could not appreciate. I don't found any chest scar mark. and I could not appreciate any feature of the anemia and jaundice. And there is a no fluid overload feature. I mean, there is a no red JVP sector or leg edema. So I need to go differential for the left hypochondriac mass.
What's your differential?
My first differential
Oh,
diagnosis is splenomegaly. And I need to go for differential diagnosis for splenomegaly.
what's your differential process splenomegaly in
My
this one?
my first differential diagnosis in this case, as I found, there is a nodule in the bilateral elbow. I believe that maybe this is rheumatoid nodule, and possibly this is a Feltis syndrome. I mean, due to the rheumatoid arthritis. This is my first
Other
differential diagnosis. Other differential
other
diagnosis is, yes, it can be hemolytic anemia, but I don't found any feature of the jaundice. It can be the chronic liver disease, but I don't found the feature of the chronic liver disease. It can be myeloproliferative or lymphoproliferative disorder, but I don't found that lymph node or anemic feature.
how you will manage this patient?
Sorry, what?
How will manage this patient?
So in this case, first of all, I need to take proper history from the patient and any medical history, any drug history. And then I need to check that vital sign like blood pressure, temperature, respiratory rate, oxygen saturation, and also that pulse blood sugar level. I can do that some basic blood tests, like including that CBC, the CRP, liver renal function test, urine test. And I need to do rheumatoid factor and anti-CCP. I need to go for ultrasonography of the abdomen, and I need to rule out other issues like I can do peripheral blood film to see that in the feature of the hemolytic anemia. I can, as I don't found that feature of the lymphoproliferative or myeloproliferative disorder. So here I think no need of lymph node biopsy or that bone marrow study, and I can do that liver function test to see any abnormal liver enzyme or not, like that.
What possible complication for this patient?
In this patient, actually possible complication as there is a splenomegaly, that spleen can be ruptured. There is a chance of the compression syndrome and chance of that anemia. Pancytopenia can develop from this enlarged spleen. And as the patient has rheumatoid arthritis, maybe there is a possible joint damage can happen, but I don't found any joint deformity here. So these are, I think, the main
Uh,
observation.
what is the characteristic finding in Feld syndrome in blood test?
In the Felty
When
syndrome, in the blood test, I found Felty syndrome is a combination of the triad, like here, neutropenia, splenomegaly, and also rheumatoid arthritis.
splenomegaly, what also?
Splenomegaly, neutropenia, and rheumatoid arthritis. It's a triad of syndrome.
Okay. Okay.
Okay, I will add one question for teaching.
Sure, sure.
If I give you time to take history, what important history you want to take in young patients?
In this case,
Okay, in this case, and young patient like this.
in the young patient, in this case, I need to check any history of the blood transfusion.
For what? For anemic or hemolytic anemia, right?
For anemia, like hemolytic anemia, to
Okay,
rule out.
what the big title, including the splenomegaly you missed? Big title in the
Actually, in the splenomegaly, first of all, I need to palpate properly. I need to check that splenic notch. Isn't actually splenic notch not found? This is like theoretical
no,
something.
I mean big title in the differential. You miss very
In
important differential.
that I said that chronic liver disease, but I don't found the
Okay,
feature of the
forget
chronic liver
that.
disease.
We heard it. Chronic liver
Yes,
disease. You mentioned hemolytic
chronic
anemias,
liver disease, hemolytic, rheumatoid, myeloproliferative, lymphoproliferative
myeloproliferative,
disorders,
lymphoproliferative. There is
and
something important in this scenario, and
I
in
told already. I
what
told
what
myeloproliferative,
Malignancy, no?
lymphoproliferative.
No?
Malignancy, I don't tell. Myeloproliferative, lymphoproliferative, I
Okay,
said.
malignancy, we can say myelo and lymphoproliferative. There is
Yes, yes,
another.
exactly.
Did you say
Okay,
the
if
infectious?
act-
Infection.
Infectious.
Infectious, I did not. Yes, I did not because
See,
actually I don't find the feature of the infection actually. Yeah.
why isolated malaria, isolated splenomegaly?
Actually, see, this is what happened. This is my practical experience. I have lots of differential about the splenomegaly, amyloidosis, sarcoidosis, malaria, typhoid, kala-jaw, splenic abscess, is the splenic vein thrombosis. But we should not tell which is not relevant here
No, no, I didn't
because it's my
specify,
practical
but I
experience.
can say infectious cause
Yes.
of malaria. I will not
No,
say
why I
malaria
want to
by
tell
name, but
you,
I will say infectious cause.
yes,
One
yes,
of
yes.
them malaria,
What,
because malaria most important isolated huge
Mhm.
splenomegaly. It's one of the causes,
Actually,
right?
isolated, if you think isolated splenomegaly, the first cause will come splenic abscess, splenic vein thrombosis. These are the main isolated cause. But what happened? This is my practical experience. I
Yes, it's
found
not.
huge
Mhm.
splenomegaly in my exam, and I said, when I said all the things like chronic liver disease, myeloproliferative, lymphoproliferative, rheumatoid, hemolytic anemia, then examiner asked, what? I said later that it can be amyloidosis, sarcoidosis. I mean, infected. It can be infected, like infective endocarditis, malaria.
Yes,
That
yes.
examiner examiner immediately asked me, "Did you think this is a infected case?" Because infected case usually they are not bringing. So examiner catch my question. Did you think he is infected? You found any feature of the infected, like unstability of this patient? You feel that when you touch, you feel febrile, this patient. That's why actually I
Yeah, that's
want to
why
avoid this.
we want to improve our differential. That's why I make this session for short cases. They are judging us on differential in short cases while you don't know the history. How I give you differential and I don't know clear history and detailed history. I
Yes,
just
yes,
examine the patient and you want me to give good differential diagnosis. You got it? So we want to know
yes,
what
yes.
they are thinking about. We want to be more target to the differential. That's why I try to make this session for short cases as
Yes.
will
I
ask
have
for others.
actually little little different opinion. Differential diagnosis should be which is more relevant because if you give irrelevant differential, it will make another type of the problem. They will ask what you found for this differential.
Exactly,
So
yes. You
that
will.
time it will be difficult. What I'll say in the positive finding in this case.
Yeah, so let's
So
make it. We will categorize it again. Let's Dr. Marwa
yes, yes,
comment.
exactly.
Dr. Marwa comment. Then we will have a discussion after that. Please, Dr. Marwa.
Exactly.
Yeah, talk
Thank you.
about your topic.
Yeah, I don't have complaint يعني it's just for splenomegaly for differential. As you said, infectious is part of differential, myeloproliferative, also storage disease زي الكشر
Okay.
blood disease, hemolytic anemia. In this patient is Feld syndrome or
Felt it.
splenomegaly for differential.
So it's this the olecranon or the cubital. You said cubital lesion.
Cubicle?
Elbow nodular.
Elbow.
It's a rheumatoid nodule.
Elbow.
Rheumatoid nodule.
So it was rheumatoid nodule, Dr. Marwa, right?
Exactly.
Yes, yes.
So I have to say rheumatoid and felty. This is the first differential and possible accepted differential, right?
Mm, yes.
Exactly.
Perfect. Okay, what else? I could put it as differential rheumatoid with felty syndrome. We have background of rheumatoid now, and the patient having splenomegaly. What do you expect, Dr.
Mm.
Tanvir or Dr. Marwa?
Sometimes Joker and cystic lupus have splenomegaly also.
Even
Jogoran?
that mixed syndrome, but there is a no joint deformity in this case. That is important thing. Supposed to be if there is some joint deformity, skin rash, we can tell other
Yeah, suppose
connective
yeah,
tissue
supposed to
disorder.
have some joint deformity. Yes, you're right. And please, even you have joint in the short case abdomen, mention it on an inspection because it could be
Exactly.
related to the case. Don't skip it. Yes, it's irrelevant to the abdominal examination and it's not related to the abdomen by direct way, but still one of the finding I should explain and I should enumerate to the examiner. Okay.
Okay, but this case may come without deformity also. May
Yes, I,
come
I
also
agree.
with
I,
Yes,
I,
yes.
I'm
Maybe
splenomegaly
saying
or
treated. Now here
I'm
important thing is that maybe treated. You will treated case, you will not
exactly.
found typical
I'm saying
deformity.
if you have, you have to mention. If you don't have, don't invent. But I am saying
Yes,
it
yes,
might be
exactly.
there. So we have to mention it.
Exactly.
As Dr.
You know
Tanvir
that I
did.
got a
Mhm.
rheumatoid arthritis case. He's taking methotrexate injection, and subhanallah, he don't have any deformity. That time I asked that
Perfect.
as you are rheumatism patient, you are taking methotrexate. Did you have before that any like joint deformity? He said yes, I had before, but with taking medication, alhamdulillah, I improved.
Yeah. Okay, good. That's perfect. So, I mean, please try to mention by inspection first, as Dr. Tanvir said. And he did a lot of inspection before starting. Although it's wasting the time, but it's important. The inspection, they like the inspection as a step. What you notice around the patient, surroundings, even by the shape, there is a hernia, there is scar. You have to mention before giving the last finding or the related finding, which is splenomegaly. Try to mention those things. If you miss these things, you might have deduction in your marks. So it's important to mention what you inspected before mentioning this is a case of splenomegaly. If you mention splenomegaly, he will just take the word from you and he will ask you what the splenomegaly causes, what the differential, and you never get a chance to mention and to enumerate what other findings in this patient. And of course, the mark system will be affected either from physical examination or identify the finding. So please start by inspection before mentioning the splenomegaly or the last finding which is related to the case. Okay, as Dr. Tavir did exactly. If you want, all of you, I need someone to say, or all of you, if you want to repeat the steps, or we have to do the discussion only as you like. Let's have a vote for that. You want to repeat the steps for abdominal examination in quick manner, or you want to have a
Yes,
discussion?
repeat examination.
Okay. So as I will try to make as simple as possible and quick also. Exactly as Dr. Tanvir said, introduce yourself. You will confirm the patient name and some alarming or warning that my hand might be cold. I'm sorry if you have some pain. Let me know if you have some discomfort. I will try to be gentle. Then I will stand, as Dr. Tanvir said, 2 steps back away from the bed to check for any surrounding, or even I will check for the patient look. If he's morbid obese, if he has some hernias, scars, characteristic features in his face. Then some people starting from the legs checking for for ankle edema because you are already standing at the end of the bed. You can check the ankle edema before proceeding. This is what I prefer also. I am doing that. I am standing, so I can check the legs before going to the head and abdomen. It's okay to do that. If not, remember to do it at the end. Anyway, let's go to the hand. You will ask him to extend the hand by inspection, any clubbing, any deformities, as Dr. Tanvir tried to find, or anything you can find by inspection. Pallor, as I said, the clubbing already, pallor in the face and the palm, sorry, and palmar erythema. If no, proceed for the tremors. Please extend your arms and separate your fingers, then extend the arm backward for the flapping tremors. So first for fine, then for flapping tremors. You finish this part, go forward to the elbow and forearm and arm. Try to inspect and to pick up any injection marks, any fistula. Sometimes you have a kidney patient or renal replacement therapy, so you have to examine for any scar in his hand. Even a small scar, mention it. Even it's not relevant to the case, please mention what you notice. Even simple scar. Injection mark, if a fistula, then proceed further to the face. Notice, ask the patient to look up for any pallor and for any jaundice and look down for any pallor. So ask the patient, don't touch him. Just let him do like you by your hands. Look up, look down, and pull your eyelid up and down. Finish this. If you have some maxilla or facial characteristic of sickle cell or thalassemia, also notice it, notify it to the examiner either now or try to make it at the end in the summary. Open your mouth, please. Check The dental hygiene, teeth, any even gum hypertrophy, you can check. Let him do smile for you. Please, can you smile for me and check for gingival hyperplasia. It will be important if the patient is taking immunosuppressant. Now the time for inspection of the chest and abdomen. Please, whenever you inspect before putting the bed flat, check for any spider nevi, gynecomastia, axillary hair. All this would be in the chronic liver disease station. So try to pick up all these things. Any hernia, scar in the abdomen, scar in the chest, just by yourself and by your hand, point to it and show the examiner that you see it. The next, check the back for also again spider nevi. You might have spider nevi at the back and caput medusa around the umbilicus. This is for inspection. Now the time for palpation. Now you have to put the bed flat before proceeding. If you didn't put the bed flat, maybe you fail the case. So you have to put the patient is in 0 degree or the bed as 0 degree and start to examine superficial palpation by, as we know, the steps of superficial palpation, either area or as rotation movement around the tummy. If you feel any mass, notify it. If you feel the mass like kidney transplanted, try to do good palpation around it. Is it tender? And while you are palpating, put your face toward the patient. You have to check if the patient is feeling tenderness or in pain. If you don't do that, they will minus you. Okay. Then we will go for deep palpation. First of all, the liver. I will start by the liver from down. Take breathe in and out until I will feel the liver. If I feel it, I will make the liver span by percussion from down and from up. Then I will make like estimated by fingers how many fingers below the costal margin. So each finger equal to 2 centimeter. If you feel it one finger below, it will be 2 centimeter. If two finger, like 4 centimeter. You finish the liver, you go now to the spleen, started from the right side toward the left hypochondrial. Whenever you feel it, try to ask to take breathe in and out again to feel the movement with the respiration, to feel the notch. Although it's sometimes difficult to feel the notch, but if you feel the spleen, it's okay. If not, you will ask the patient to bend to the right side and to palpate it again. If not, do the percussion. Let him be in the supine position again. Percuss from the right side till the dullness will be there. So you will just point to the area of the spleen, either to the umbilicus, extend the umbilicus, or whatever. You finish the spleen. Now the time for the development of the kidneys, as we know how to do it, the right and the left. If we finish it, we will do the shifting dullness. If you have splenomegaly, please do the shifting dullness to the right side because the spleen will mask the finding. So you will percuss over the umbilicus toward the right side, the flank. Then ask the patient to bend the left side or left lateral decubitus. Count for 5 seconds. Then percuss again. The fluid will be disappear or the percussion will be resonant. So the patient is having shifting nullness. What if the patient is having tense ascites? Ask the examiner to put his hand in the midline and make the thrill. Okay. I forget to mention the axillary lymph node. You can ask the patient while like flat or while he's sitting, and try to palpate the lymph node in the axilla. Okay, there's
Supraclavicular also lymph node.
supraclavicular. Okay, it's
Yes.
difficult to palpate, but the axillary is a palpable one. Okay, this is the steps in summary. And when you present, as I said, from inspection, then the palpation, the percussion, if there is chronic liver disease finding, you have to mention them one by one. Spider nevi, caput medusa, whatever. Then you have to say, if you have renal patient, you have to say the volume state, You have to mention if the patient is having signs of heart failure. You have to mention if the patient is not having, even by negative. So this patient, I examine this patient is having blah blah blah. Then at the end, the patient is not having any signs, hypervolemia, no signs of heart failure, no signs of chronic liver disease. If he doesn't have, for example, but if he has, you have to mention them, and you have to mention the negative as well at the end. But don't mention the negative first. This is like complementary after finishing the finding. Clear for all? This is the steps and how to present. Let's have a discussion now about isolated splenomegaly and the most important differential, please. If you are in Egypt,
Uh, Sorry, Dr. Bassam, before we proceed, just regarding the cervical lymph node examination and the supraclavicular, because the lymphatic drainage of the abdomen will be to the supraclav, and the cervical lymph nodes may be enlarged before the axilla. If I
I
wrong, or
used to
what?
I used to do the cervical with chest examination, chest cases, and the axillary for the abdomen. But if you have time, because sometimes you don't have time to check all lymph nodes, and it's difficult to feel all of them.
It will take time.
Yeah, it will take time, and it will be difficult to feel them. I guess one lymph node group, or I mean the axillary, for me is enough to just examine. Okay, in
The auxiliary
Egypt,
also, it will take time, because he will take put his arm on my arm, and this
yes,
also,
yes,
it is
exactly,
also not
yes, yes, but you have to do them.
okay.
Okay, so let's talk about the differential, especially in endemic areas. So in Egypt, for example, if you missed the hepatitis as a cause of chronic liver disease in the differential, you'll be in trouble. In this scenario, if you are in Egypt, you have to mention even you have a splenomegaly. So it's okay. The patient might have splenomegaly with shrunken liver. What the cause of shrunken liver? In,
Cirrhosis,
so cirrhosis and the possible and the most sensible differential in Egypt of cirrhosis as a cause what?
hepatitis virus C.
Exactly hepatitis. Yeah, he will ask you which virus exactly. So as you said, C in UK, B or in Europe. Let's go to the next sensible differential in Egypt. He might ask.
Bilharziosis, bilharziosis.
Perfect, perfect. So you have to mention in this order. Why? Because you are examining patient in Egypt. If let's assume you are in another country, not in Egypt, what you will mention in the first, let's say in Europe, in UK or Europe, what the first sensible differential for this case? Splenomegaly with shrunken liver.
Alcoholic,
Exactly. Alcoholic on the top. You have to mention alcoholic liver disease. Then you can
NASH
say
also.
non-alcoholic, exactly, after alcoholic. Okay. Hepatitis you can mention, but hepatitis B. Bilharzisis, don't give a differential of bilharzisis in UK. It's not there at all. But you can give it in Egypt. As well as in some countries, Gulf countries. If, for example, if you examine a patient Egyptian, so you can say this. Or even some Sudanese also patient, they have bilharzisis. So it's endemic in Africa. Please put differential linked to the country you are examined in. Okay. This for the splenomegaly with shrunken liver. And don't forget also to mention other causes like infectious. As we mentioned, malaria. I have to take a full history, travel history to say if this is a malaria or infectious. Other causes would be isolated splenomegaly, as Dr. Tanvir said, hemolytic anemias, or myeloproliferative or lymphoproliferative. Proliferative itself, you can say amyloidosis, hemochromatosis. So please put it as a categories. Don't mention disease name or by name. So don't say malaria. No, mention the infectious cause, the infiltrative cause, the malignancy cause,
most
alcoholic.
common infectious اللي هو Epstein-Barr virus.
Okay.
Splenomegaly lymphadenopathy.
Yeah, of course. With lymph node, of course. Yes, you're right. Okay, any question? We have to open discussion, and I want to hear the question because it's an opportunity to ask about this topic. By this differentiation, you have to know how to differentiate between isolated splenomegaly or splenomegaly with hepatomegaly, or
This question may ask the causes of huge splenomegaly.
yeah, they are four. You know them, Dr. Marwa? The huge splenomegaly causes.
في chronic myeloid leukemia وبالهرزيزس وكلا أزار وأيضا
Kala azar, no, not bilharziosis. Kala azar, malaria, chronic myeloid leukemia,
Yes, بالهرزيزس causes huge
myelofibrosis.
splenomegaly يا دكتور.
Myelofibrosis.
CML.
myelofibrosis. Exactly, yes. CML, I mentioned chronic myeloid leukemia, myelofibrosis, malaria, and Kala azar. These are the cause of huge spleen.
Yes.
And this is a unique question. He might ask you this question particularly. So please prepare the
بالهرزيزس
answer.
but also cause huge splenomegaly. I remember from study in college يعني they called it Egyptian splenomegaly. Very huge splenomegaly.
Okay. I'm not sure.
Advanced portal hypertension as well.
Yeah, if there is advanced portal hypertension. And it's not mentioned in past test. I don't know. Maybe they
Yes,
are mentioned.
otherwise it's not differential.
Yeah. So yeah, put what we mentioned already, Dr. Maro. These four are common, and the examiner want to hear them.
Gaucher disease, even I think I remember.
Gaucher as yes, genetic. Sorry, it's
Gaucher
storage
as the
disease.
infiltrated,
Sorry.
as the infiltrated, as the
Yeah,
storage.
infiltrative storage
Metabolic
disease.
error.
Glycogen storage.
Metabolic error.
Metabolic or storage disease, whatever. Okay.
Yes.
Okay. Any comment, Dr. Tanvir? Sorry, this is your case. If you want to
No,
add
no,
something we mentioned
it's okay.
or
It's
we miss.
okay. Yes, actually, like there is another differentiation sometimes coming. That is, what is the cause of the large splenomegaly? As you mentioned already, infective
Yes.
like malaria, kalajar, myeloproliferative, lymphoproliferative. So if there is a mild or moderate, so we can add other causes first in the mild
Yes,
cases and moderate
exactly.
cases.
Yes,
But
exactly.
and another causes is sometimes splenomegaly, but you will not found that feature of that chronic liver disease. I mean, but we can tell there, like if you feel this is also liver related, but not typical. So you can tell it in the like compensated liver disease. I mean, under control. Patient is not,
Exactly.
it still goes to the decompensated stage, like
Yes.
initial stage. So
Yes,
compensated liver disease is another disease.
Yes. Perfect. Thank you, Dr. Tanvir. Now yeah, go ahead. What you want to say?
Okay, so I will, okay, no, I just, I will give no case.
Yes, mention it, please.
Okay. Okay, so Dr. Marwa, ready?
Yeah.
Okay. So there is a 40-year male. Please examine his abdomen.
40 years old male.
Yes, 40-year male.
Examine the abdomen.
Examine abdomen. Yes.
Okay, so we'll go ahead, Dr. Marwa, without waiting. This is the way in the exam you are doing. No time to think. You will just proceed for the examination. Go ahead. Here you go.
I will enter the room, greeting the examiner, looking for the wall, washing my hand by alcohol. Then I will go to the patient. Hello, good morning. My name is Dr. Marwa, doctors in the exam today. I'm going to examine you. If you feel any pain or discomfort, please let me know.
Okay, doctor.
I will take 2 steps backward and looking for the general condition of the patient and the surrounding. Then I will go to the patient, examine his hand, looking for the palm and the dorsum of the hand and the nail for any abnormalities. Any abnormalities in hand examination?
Okay, you found there is a like that underbody wheel patient in the bed lying, and it looks like little pallor. Okay, and in the hand examination, what you want to check in the hand?
Any palmar erythema, any different contraction, any wasting of semen, hypoxemia.
No, it's not like that.
In nails, any deconychia, any clubbing, any
You
splinter
can
hemorrhage,
feel like slightly pallor hand.
pallor in hands.
Yes.
Okay, I will ask the
Slight.
patient extend his arms, looking for any fine tremors.
No
Extend the
fine
arm
tremor.
and fingers, and extension of the wrist for any clamping tremors.
No,
Flexion.
no fine tremor. No fine tremor, no flapping tremor.
Okay, I will examine the pulse for rate, volume,
Yes.
and
Pulse
water
is
hammer
like
and collapsing pulse.
water hammer collapsing for what purpose you want to check?
I will ask the patient, do you have any pain in your shoulder, and then elevate
But for what purpose in the abdomen?
for what?
For what purpose in the abdomen? Water hammer pulse.
يعني any cause of
It's related with the aortic
Okay,
hyperdynamic.
proceed.
Okay, but no pain in the hand. Okay, no pain.
No abnormality in pulse.
No, pulse is a slightly low volume but regular and
Okay.
normal rate.
طيب, okay. I will go to examine the patient eye. I will ask him to pull his lower eyelid by one finger, looking for any pallor or jaundice.
Slightly pallor, no jaundice. Do you anything check in the hand?
In the hand?
In the hand, arm, forearm, anything you need to check?
Yes, I will. Yes, I will search for any fistula or needle marks.
No needle marks, but there is a swelling in the antecubital area.
I
in
will
the right
palpate
hand.
it. I will palpate the
It's a
swelling.
soft and vibrating like
Any thrill? Thrill?
Sorry, what?
Thrill?
Yes,
Any
you can
thrill?
feel. Yes, you can feel there is a thrill.
I will palpate this swelling.
Yeah, there is a slightly thrill, not much vibrating.
Okay. I will ask the patient to open his mouth, looking and inflate his tongue, and show me your teeth. Any abnormalities in mouth as ulcer, gingival hyperplasia?
What you want to check in the mouth?
For oral ulcers, gingival hyperplasia, cyanosis.
No oral hyper. No oral ulcer, no cyanosis, no pallor. Anything you want me to check in the mouth? More?
Gingival hyperplasia, you say that?
Some gingival hypertrophy.
Okay, that's it. I will ask if the patient not expose his abdomen. I will ask him to expose abdomen and chest. I will take general inspection for any scars or spider nevi or gynecomastia. And
Why do you
activate
check
air.
the scar? Which area
Any
you would want
scars.
to?
Any
Scar.
scars
Yes,
in
you found
abdomen and chest.
in the right upper chest you found a scar, but old scar.
Right upper chest.
Old scar, yes.
Only this scar.
Yes.
Okay. Then I will go to the end of the bed, examine the dorsalis pedis pulse, and examine for any lower limb edema.
No limit.
1 minute left.
1 minute. Okay, I will
In the abdomen,
make
what
the
you'll do?
I will make the patient as a bed flat, and will do superficial palpation at the level of the patient, at the level of the abdomen, and looking for any looking on the patient's eye for any tenderness at all area of the
No
abdomen.
tender.
Then
No
I will
tenderness.
do deep palpation starting from right iliac upward, and ask the patient
Okay,
take breath.
before palpation, what you'll do? What you'll do in the abdomen? What you'll see in the before palpation?
Before superficial palpation.
Before touching patient abdomen, what you see in the abdomen?
You will tell me what you see. I said I will look for chest and abdomen by inspection. You tell me what
Okay.
I.
Okay,
And for
abdomen
any scars, any
non-distended,
bulging, any. Mm,
non-distended abdomen. Okay, in
mm.
the palpation you will found there is a mass in the left iliac fossa.
Mass in right iliac fossa.
Left
طيب
iliac
this
fossa.
any
And you found there
organ
is a,
liver, any
you
liver or
found that,
spleen enlargement. Mm.
no liver spleen enlargement, you found
Any
only left,
kidney and any kidney enlargement.
no kidney enlargement, left iliac fossa mass, but you found
Mm.
there is a multiple scar. In the one laparotomy scar, one some non-specific scar, and also left side there is a fading scar.
Scar where is the scar? In the right
Yes,
iliac.
Multiple scar, midline and
multiple
above
scars.
chest
Midline.
and
Oh,
left
left
iliac
line.
Midline and
fossa.
some non-specific scar, and also there is a left side scar.
Okay, طيب إذا mass in right iliac fossa, I will palpate it.
Left
Any
iliac fossa.
tenderness?
Doctor, left iliac fossa.
Okay, left iliac. Any tenderness in it?
No tenderness.
Percussion by percussion.
Yes,
The
by
mass
percussion, light percussion, no tenderness.
dull or resonant.
It's a dull.
Okay. By auscultation, any bruit.
No bruise.
Auscultation.
No bruise.
I need to do rest of abdominal examination for ascites to detect any ascites percussion. By
No
percussion
abdomen
left
distension.
central then to
No,
the flanks. No,
no
no, no
non-distended
ascites.
abdomen. In the physically non-distended.
Auscultation in the para-umbilical and in right iliac. Auscultation for any intestinal sounds or any bruit.
No renal bruit, no venous sound. Normal bowel
Okay.
sound.
Okay, the time is up. 8 minutes. I added 2 minutes. Now the presentation. Please, Dr. Tavir, start the questions.
Okay, present the case, please.
Okay. My case is 40 years old male patient with end-stage renal disease, evident by transplanted kidney. I found transplant scar in the left iliac with palpable mass, which is not tender, dull in percussion, with evidence of past mode of renal replacement is central hemodialysis, central line hemodialysis, and fistula, which is functioning but not recently used. I can detect some signs of immunosuppressant medications in form of gingival hyperplasia. So this case is in the stage renal disease with renal replacement graft, which is functioning.
Okay, what are your other differential here
For this mass, for what?
for this mass? Yes, exactly.
Um, in left side,
Don't think, Dr. Marwa. It's
I don't,
time to answer quickly. 4 minutes
I don't
only.
know.
They
Okay,
have only
skip.
4 minutes. They don't have enough time to
Yes.
wait. Huh? So just
Don't know what the differential for this mass. Can remember me.
okay. So did you found any complication, anything here, like
Yes,
anything extra
I
other
found
things?
the gingival hyperplasia, which indicates as the complication of uh, immunosuppressant medications,
Mhm.
like
Any
uh,
other thing you found?
I didn't found any other thing.
I told you another finding I told you. Anyway,
What?
so I told you before, pallor. I said you multiple
Valor?
times.
Yes, yes, valor.
There is a pallor. Should not forget
Yes.
pallor in case of the kidney disease
Okay.
because anemia is the one of the complication of the chronic kidney disease. Anyway,
Yes.
so you think that this is a renal transplant. Okay, what are the complication of the renal transplant can arise?
Complication is acute rejection or violent rejection, infection in the graft, or complication from the medications after the transplantation. Acute
Any
rejection
other?
occur
Is there any carcinoma can happen in the renal transplant case?
in what? In what?
Any carcinoma, any malignancy can happen?
Carcinoma? Yes,
What?
may occur in the transplanted graft.
Okay, how will you investigate this case?
I will do basic investigations in form of CBC, complete liver function and kidney function, and electrolytes. I will do ultrasound abdomen and the level of the medication he take to detect
If you
any
found
toxicity.
that transplanted part, I mean that mass is tender or patient is febrile, what is your one investigation, the most specific investigation? What you will do?
Doppler ultrasound on the graft.
Another more? Any other?
Um,
Okay, how will you manage this case?
what is complaint?
Like this case, same patient. Like how will monitor this, or how
I
will make
will
follow up this?
I will check his the graft condition and the medication level in the blood for any toxicity, and assess the kidney function, renal function, and electrolytes, and also signs of I didn't detect any signs of hypervolemia in this patient. I forget also some steps in examination.
Okay, thank you, Dr. Marwa. Thank you.
Perfect, Dr. Marwa and Dr. Tanvir. Really nice presentation and nice question by Dr. Tanvir. Now you can comment Dr. Tanvir, and then we will have
Okay,
discussion.
thank you, Dr. Wasim. Thank you, Dr. Marwa. I think Dr. Marwa need to be little more fluent. Ah, because you know that here 6 minutes only and 4 minutes your viva. So you get this case, renal case. So after entering the room, after washing and introduction, you see the general look. General look is a very important thing for the any patient. Like patient can be edematous, can be anemic, can be dehydrated. So many things can happen. So you need to check that patient facial expression, like if that looks like actually bad looking or any facial edema, then you can check the general that you can found there is a at a AV fistula, you can even general looking you can found any scar mark in the head, any maybe steroid using or something. And then you can go any deformity, even you can see the deformity because connective tissue disorder, one of the leading cause of the renal failure. So you can go after that in the downside, I mean, in the leg area and in the general abdomen, you can see it's ascites plus. As you said, there is ascitic, you do shifting dullness. So actually, if you found distended abdomen or everted umbilicus, so that time better to go. Otherwise, if patient is sunken abdomen, it's not distended. So it's typically not, even there is a no flank full. So if you do that time shifting dullness, I think maybe it will deduct your skill
هو shifting
they will
dullness
deduct.
for moderate ascites, but
Yes,
if the abdomen is descended, we'll do transmitted thrill.
yes. But if a patient looks like sunken abdomen or normal abdomen and umbilicus in the normal position, and you can see that dullness, there is a no like distended abdomen. So better not to do if you feel that this is not a satis case. Then in the leg, you found, as Dr. Basim mentioned, when you are going to the near to the leg, you can check that leg edema. You can check bedside surrounding anything patient with that maybe patient has insulin pain or maybe patient has some catheter. Anything can present in this patient. Okay, then when you go to the front, you can find there is anemia jaundice. What you know that flapping tumor, fine tumor, like there is a toxicity can cause the fine tumor or flapping tumor due to the renal failure. I mean that uremic encephalopathy. Patient looks like tired and looks like dizzy or something, like if you feel that cognitive or consciousness level is poor, so that is one of the feature of the encephalopathic feature. Or if you found there is a scratch mark in the body, this is a sign of the uremic encephalopathy, like that, uremia. And when you go to the up, you found there is a, yes, there is a fistula, and fistula, when you touch this, you may found that vibration sensation. Because if I get any patient with the fistula, I'm immediately touching in my practice. And all the time I found there's a vibration. You can feel something like mobile vibration. And you can check that needle prick mark, no needle prick mark, that means not recently used. If you found there is a thrill, you can check the bruit. So bruit is important to check any functioning. So one is recently used needle prick, and if you've not found needle prick, bruit and thrill found, that means it's a functioning. Then you can check that when you found there is AV fistula, you immediately check for the scar mark in the neck, like tunnel catheter or a Barber catheter, like that. Maybe present or maybe oldest or something. You can check the anemia, jaundice. If there is a liver feature, liver disease, you can find jaundice, and anemia is one of the feature of that implication of the chronic renal disease. You can find in the joint swelling also as a connective tissue disorder feature. Then in the chest, in the kidney case, usually chest under the stomach, otherwise the splenomegaly gynecomastia, it's usually for the liver cases. Then when you go for the abdomen, in the abdomen you can find there is a multiple scar mark, a single right or left scar mark. So you need to very clearly see, because sometimes the scar mark becomes fade. So after that, you can make a superficial palpation, then the palpation by warming your hands. So when you palpate properly, 9 quadrant, you can find the mass. As I said, you left the lymphoma mass. So when you first get the mass, immediately you have to assess the mass, like palpate, any surface, any consistency, any movement, then any percussion, then auscultation to see any fluid or rub, and the consistency, any tenderness, any roughness. Tenderness means there is a feature of that, maybe there's a graft, rejected graft, something. And when you confirm this mass, after that you need to check other masses like liver masses, splenic masses, polycystic kidney masses. So you can found maybe polycystic kidney, because one is done for the renal transplant, maybe another is polycystic kidney disease. In case of if patient is polycystic kidney disease, one transplant is done, maybe another is still has polycystic kidney disease. So you have to check palatable, then liver, and also splenic. Okay, then you can see if SITs, you can do shifting dullness like that fluid thing. Then you need to go for a auscultation, bowel sound, renal buoy, then ASAM, like that. You can see also there is the capillary medusa in case of liver disease. Then you need to go for back. You can check the lymph node. Lymph node is one of the marker of infection. So even the very important thing I ask you, that is there any carcinoma can happen post-transplant lymphoproliferative disorder. This is a one of the leading cancer which can develop after the transplantation. That's why you have to check the lymph node. If you found cervical lymphadenopathy, you can check that axillary lymph node. And lymph node better to palpate one side, one by one, not together. Then you can go for the sacral edema, leg edema, because sacral edema, leg edema is yes, gentle
Sorry,
percussion
Dr.
of
Tanvir,
course.
which cancer? Because we are so rapid.
Sorry,
Pyeloproliferative or lymphoproliferative?
Which cancer
yes,
after renal transplant?
post-transplant lymphoproliferative disorder, PTLD. This is one of the important, like
Skin
carcinoma can
cancer
happen.
also.
Skin
Yes,
cancer, I think.
skin
So
cancer
no, that
also
is
in the
the
neck.
that is the different. First of all, we come for the lymph vein. Lymph node is enlarged. We can think it's a post-transplant lymphoproliferative disorder. Then when coming that presentation like that, you immediately said it's a renal transplant. So I think better to tell. I believe that this is a case of the in the stage of the renal disease, as evidenced by there is a arteriovenous fistula which is functioning but not recently used. There's also stomach, and I found there is a mass at the left iliac fossa which is non-tender, firm in its consistency, and that auscultation there is a no bruit. And it can so after that, examiner can ask what are the DD of that that left iliac fossa mass. That time you can say it can be happen tuberculoma, lymphoma, colonic mass. These are important. Ectopic kidney is female. it's that ovarian cyst can be found like that. If in the right side, this is left side. If in the right side, we can add some other more like fecal carcinoma, appendicular mass, Pons disease, carcinoid syndrome. So this is the DD of that, mass in the left or right iliac fossa. Then we always should be present any transplant, even liver, in any renal or lung transplantation. We have to tell what we found this mass and what is the character of the mass, what are the possible cause of the renal transplant. So you know that younger patient, we can tell it's an autosomal dominant polycystic kidney disease. Then we can tell diabetic and hypertensive. Usually we can tell as a letter, we can tell glomerulonephritis, analgesic nephropathy. Then we can add diabetic nephropathy and hypertensive nephropathy, even tuberous sclerosis. This is important differential. But if you found this is a case of elderly, so you have to bring hypertensive and diabetic nephropathy initially. Then you can take analgesic nephropathy, glomerulonephritis, obstructive nephropathy, analgesic nephropathy. Then you have to go for any complication, because any transplant case, we have to mention the complication, like what complication can happen, fluid overload. So in this patient, I don't find the fluid overload. If there is hepatic encephalopathy, you need to actually take the history, so it will not come here. Then it's working well, and there is a non-tender and no feature of the fluid overload. But I found there is a pallor. It's probably due to the anemia, due to the chronic renal failure. So you have to mention like that. So any fluid overload, any feature of the encephalopathy, or scratching marks, or flapping tumor, or dehydrated, or fluid overloaded, you have to mention any complication associated or not. Then you have to come for immunosuppressive therapy. I found that a patient has a gum hypertrophy is probably due to the cyclosporine, immunosuppressive therapy. If you found flapping tumor, it can be the tacrolimus. If you found skin thinning, it can be the steroid. So we need to think a steroid, azathioprine, any tender graft. It can be the tender graft, can be infection, can be rejection of the transplant. Then you have to come, what are the complications? Examiner can ask, what are the complications can develop after transplant? So there is a acute rejection, chronic rejection, thrombus, infection, recurrence of the original disease, then immunosuppressive related disease like that, skin thinning, papura. Then you can find gamma hypertrophy, fine tumor, flapping tumor, then diabetes, hypertension. Then it can be associated with the opportunistic infection like cytomegalovirus infection, Epstein-Barr virus infection. It can be the skin cancer like squamous cell, basal cell carcinoma, malignant melanoma. Then you have to add also post-transplant lymphoproliferative disorder. Then how we investigate this basic investigation, including that urine, CS, and you can do ultrasonography if you feel this is a case of the rejection or pain, tenderness, febrile. You can do offer renal biopsy, because biopsy and also Doppler ultrasound, we need to rule out any thrombus, any rejection. We can confirm by the biopsy and the Doppler ultrasound. Then you have to follow up this patient education counseling. Patient have to
Do what
counseling.
do what for rejection investigation? What investigation for rejection?
If rejection, the specific investigation is biopsy. If thrombus, Doppler ultrasound. So if you feel that painful, tender, that mass, you have to rule out any infection, any thrombus formation, any rejection. It can be acute, can be chronic rejection like that. So after that,
infection, blood
cytomegalovirus
culture.
is the most common virus.
yes, cytomegalo and Epstein-Barr virus, even pneumocystic cardiac pneumonia. In case of the lung, it can happen more. So viral infection can happen. Toxoplasma can also happen. These are all our opportunistic infections.
What's the investigation? What's the investigation?
So investigation, according to, if you found complication, you have to go for more investigation. If you not found the complication, you have to do routine investigation like CBC, SSCRP to see anemia, to see inflammatory marker.
General and specific as
Yes,
general and specific.
yes. General like CBC, SSCRP, liver renal function test, urine test. To see any inflammatory marker, to see any anemia, and also that for liver function, because maybe hepatorenal syndrome can happen, renal function test, electrolyte, and also urine for protein, glucose, nitrate, RBC like that. You have to go for like then ultrasonography of the abdomen, Because if there is a chronic renal disease or if there is another kidney polycystic kidney disease, we can found in the ultrasonography.
Drug
You have
level
to
also
do
for
drug
toxicity.
level, exactly.
Mm.
Toxicity, drug level. And also you have to do biopsy if you suspect this is a case of that transplant rejection, or you can do Doppler ultrasound, as you mentioned, to rule out any thrombus. If you feel painful, the thrombus, infection, rejection, we need to rule out. And after that, you know that basic that non-pharmacological patient approach, patient education counseling, you have with the offending drug, and also nephrologist and specialist nurse will involve. If there is occupational social worker, they need you need to involve. If patient is diabetic, if you found needle pick, not diabetologist, and after that you need to regular follow up and treat according to the complication. Like if you found thrombus, anticoagulation, if infection treatment, if you found skin carcinoma, you need to dermatologist. Like according to the post-transplant, what are the complication arise, you have to involve that department and that type of the treatment you need to involve.
Well,
I think
acute
that's all.
rejection within 6 months, right? Acute rejection.
Acute
Yes.
rejection within 2 weeks to few months.
Yeah.
Few weeks to few months. Hyperacute within hour.
Within hours.
Hyperacute
Yes.
within hour can happen. And acute can be happen within few weeks to few months. Chronic usually after the 6 months.
Yes, exactly. Yes.
I
Thank you.
think that's all. No?
Yeah. Thank you. You make it explained and detailed one. Perfect. Thank you for the preparation. I will just add some few finding you might have during the examination. If you suspect patient is having nephropathy, don't miss the checking or glucometer check marks in the finger, just to know what is the underlying pathology of your kidney. So if you find some glucometer check marks, please notify it, because you have to mention it was the cause of the kidney damage. The second thing, you might have also insulin CGM, continuous glucose monitoring over the arm. It's like a pad, very small pad over the arm, and also it guide you to the diabetes, and the patient is having underlying uncontrolled diabetes might be the reason of kidney disease. Then for the back, as Dr. Tanvir mentioned, you have to examine the back for two things: either a scar for a nephrectomy, previous nephrectomy, and auscultate the back for the volume overload. If you have bibasal crackles, this is a signs of overload, and you have to mention these three things while presenting this patient. Apart from the positive finding you mentioned already, Dr. Marwa, you have to say, I could appreciate there is possibility of the underlying cause. What is the underlying cause of the kidney damage? Either polycystic kidney disease or diabetes, if you feel some glucometer check marks in the finger, or hypertension. Of course, you cannot know the hypertension unless you have retinopathy, for example, by fundoscopy, but you cannot guess it without with some finding. This is for the underlying cause. So you have to mention what is the possible underlying cause. You have to mention what is the renal replacement therapy method now ongoing. So if you have needling marks over the AV fistula, you can say he's undergoing active dialysis or current dialysis or RRT, renal replacement therapy, through the AV fistula. How to know that? Crust over the AV fistula, plus functioning AV fistula by either Berwi by palpation or thrill by palpation or Berwi by auscultation. You can mention this. The third thing, the use of immunosuppressant medication, side effects, either stria for steroid, carcinoid features in the face, or bruises over the skin. This is for steroid. For tacrolimus, you will have some tremors, and it might be masked by uremic tremors. Then the last one, the cyclosporin, you might have some gum hypertrophy. I guess the tacrolimus also causing gum hypertrophy. Is it Dr. Tanvir? Which specific for gum hypertrophy? Tacrolimus, I think.
Cyclosporin and phenytoin.
And
Cyclosporin and phenytoin. It's mainly
Cyclosporine.
causes gum
Okay.
hyperbilirubinemia, yes.
So yes, so
And
tacrolimus
tacrolimus
as a
mainly
tremor.
causing fine
Yeah.
tremor.
Yeah. So tacrolimus for tremors and cyclosporine for hypertrophy, gum hypertrophy, and phenytoin if
And
there is something.
hair growth over hair
Hair
growth.
overgrowth, yes. So at least mention it. Mention there is gum hypertrophy. I noticed, or I notice the things I mentioned for underlying cause. You have to mention if the patient is eovolemic, hypervolemic, or dehydrated. Any kidney patient or any renal patient. Because if you have patient with bibasal crackle, so this patient maybe he missed dialysis session and he came to the exam, and you will find him having bibasal crackles, raised GVP while pressing over the liver, and buffiness around his eyes, all the signs of overload. You have to mention them, by the way. These are the tips for the renal. Fortunately, we have two cases today for the abdomen, the splenomegaly, and we did discussion about them. For the renal also, we did a discussion, and it was a good case by Dr. Tanvir to be presented and to be discussed. Let's open the discussion now. Anyone has any comment, or even if he wrote the comment and I didn't write it, I didn't read it, please, he can repeat it again, or he can raise any concern, new concern, and I will try to read all concepts now and the comments written down. Any question, any
I
comment?
think, Dr. Bassem, for case
Yeah.
of renal cases, you just will mention the negative, no sign of hypervolemia and or no sign of uremia. No need to see this dehydrated or evolemic or just no sign of hypervolemia and no sign of uremia. This important negative in kidney case.
Yes, and immunosuppressant also.
Yes, and in immunosuppression, it's positive.
If there is renal
I,
transplant, yes, you're right.
yes,
Yes, you're right. Back to the scars, and Dr. Tanvir mentioned already the scar in the neck for the catheter, previous central line or catheter insertion for dialysis. You can have also cancer, skin cancer, and over the neck also. Any scar there, you might say this is related to also scar for previous cancer resection, or suspected that you don't know from the examination, but you should take history. You might have also parathyroidectomy scar for hyperparathyroidism. It's related also to renal cases, especially renal failure patients. And peritoneal dialysis scar, para-umbilicus, small incision or scar, either right or left. This is for peritoneal scar or peritoneal dialysis outlet. So you can mention also this scar. Finally, the scar for the renal replacement, right iliac or left iliac fossa. Don't forget, in UK there is pancreatic and renal transplants for the diabetic patients, the diabetic with renal nephropathy. So they are doing both together, the pancreas along with renal, and you will have very big midline laparotomy scar in the abdomen. There is some cases in UK like this. There is center, by the way, there is center for such cases, diabetic nephropathy due to type 1 diabetes. They have two organs transplant, the kidney and the pancreas. Okay.
About Dr. Bassem, you mentioned that you can mention the cause of this failure. Apart from the diabetes and the polycystic, any other thing we can find in examination about the cause?
Hypertension only, and you cannot find something can guide you.
Hypertension we can't find
Yes,
in on.
exactly. Yes. These
So
are the
only
most
these
common.
two. Oh.
In
Yeah,
this
this
young patient,
Yes.
this relatively young patient, what
type
Connective
1.
tissue
what cause
disease
for it?
also you can
Type
find
1.
I
also.
think connective
See,
tissue
see
disease,
here,
like SLE or
here,
rheumatoid
if you
arthritis or systemic sclerosis.
see,
Perfect.
doctor,
Mhm.
Yes,
here
Dr.
if you
Tan.
found there is a one kidney is polycystic, I mean
Exactly.
ballotable, and another kidney is transplanted. Even you found there is a nephrectomy, something. So
Yes,
when you
exactly.
found one kidney is polycystic, I mean ballotable, so your first DD will come polycystic kidney disease. If you found there is the needle prick mark, especially in the elderly or young patient, because type 1 diabetic patient maybe, so you can found it's a diabetic. So you are, according to your finding, your DD will come upward. And if you found that
Exactly.
blood pressure, you can ask the examiner that when you are going for head examination, I need to check the blood pressure. If
Yes.
examiner said that time, yes, blood pressure 160 over 100, so you can think it's a hypertensive case. And if you found there is the adenoma sebaceum or subungual fibrometer, your thinking should be adenoma tuberous sclerosis. So some finding you have to can catch from you when you examine the patient. And if you
Exactly.
not found any finding, that time you can tell, yes, I need to go for differential for cause of the chronic renal
Glomerulonephritis.
disease. Yes,
Glomerulonephritis.
if you found facial hypertrophy, so you can think this is a glomerulonephritis. So there's
Yeah.
just some clue of some disease. If you don't get any clue, better not to invent. You can tell I need to go for differential for
And
the
history.
chronic renal disease.
And I take history.
Yes,
Yes.
exactly. History, drug, medication history, like that.
Exactly.
Medication history is
Yes.
very important because analgesic nephropathy is one of the important cause for renal failure. And even vesicoureteric reflex, especially elder patient who has BPH, prostatic hypertrophy, they have vesicoureteric reflex, they have urinary
Obstructive.
retention that can
Yeah.
obstructive, yes, obstructive, like
Yeah.
that.
So, but please don't forget the most common three causes worldwide. In paces, I mean. Diabetes on the top, diabetic nephropathy, hypertensive nephropathy, and you can put before them polycystic kidney if you have palatable kidneys. If not, you can put it the third cause. Glomerulonephritis, connective tissue disease, amyloidosis, drug induced. Others can come after these three items. Clear now? Okay, I will add also one point for the possible complication after renal transplant. For immunosuppressant. Please do it in two major division, either general or specific. What general complication might be related to immunosuppressant or after renal transplant you can mention? Any infection. This is not related particularly to the kidney. So any infection might happen because of immunosuppressant. Post-renal transplant complication, either general or specific. The general related to immunosuppression. So patient might have any infection, cytomegalovirus, Epstein-Barr virus, TB, BCB pneumonia, any infection you can mention, or myeloproliferative, lymphoproliferative, any cancer, also related to the immunosuppression. What are the specific complications related to the renal transplant? It would be the rejection on the top. First of all, any patient with previous renal transplant, you have to mention the renal rejection as a first possibility of your differential. So you will say rejection, all types of rejection, hyperacute, acute, chronic, as we are not them. The next is rejection, recurrence of the disease. The recurrence, either whatever the cause of the underlying cause, it might be recurrent or recur back. This is how to answer in systemic way and to get the full mark for the discussion. It's 4 minutes. He will not wait for you to think. As the general advice, please, if you don't remember the answer, you can say easily skip because you will waste time to remember. You will not get this the mark for this question. You will waste the marks for the next questions. Just say skip or I cannot. I'm not sure. I don't know. I'm not sure now. Skip
I
to the.
think
Oh,
skip can be
okay. No
because
need to say
angry.
skip. Okay.
Yeah,
So I'm
I
not
don't
sure now.
know. Just I don't know. I'm
I
not
don't know
sure.
or
Yeah.
I'm not sure. Okay.
Yes.
Better not to say skip. Yeah. It's but I mean you do skip. So skip by saying I'm not sure or I don't know because again you will waste the time thinking and he will wait for you. It's okay for him. But if you say please I'm not sure about this answer, he will
And
ask
for
you other
my
question.
experience, I make
Yeah.
this in the scenario, and they didn't deduct any mark. I said I don't know, and he asked another question, and he
Yes,
didn't deduct me any mark.
exactly. He has some question to ask you. Investigation, management, differential, how to approach. At least you have to answer three of them, and you will get good mark. Okay. Any question now for this topic or the previous topic, the kidney or the spleen?
I think the differential for mass in right iliac or left iliac.
Okay, as Dr. Tanvir said, always the anatomy make clear and related differential. For the right side, there is what anatomy in the right side? Right iliac,
Yeah,
appendix, cecum,
appendix to ovarian.
ovary, in female, of course,
Mm.
or colon.
Ileocecal junction and cecum you can divide
Yeah,
them.
ileocecal, cecal, appendix, colon, and ovary in female. Any pathology you can put ovarian mass, ovarian cancer, for female, of course.
Mm. طب
In
in male
in
what will
male,
you say?
any cancer, any appendix or cecal or ileocecal. So you can say Crohn's, you can say appendicular mass, you can say cancer colon, cecal complication or cecal mass.
Lymphoma
Okay.
also.
Yeah, there is some. I mean, you can put it in general lymphoma in the colon. It's not specific to the colon, but something
No,
systemic.
In this
ileocecal, I
case,
mean.
it's scar
Ileocecal
with
junction.
Sorry.
in this case, it's scar with mass.
Yeah, appendicular mass, cancer colon, ileocecal for Crohn's disease, infection, TB. There is mass. Okay.
Mm.
Ovarian mass, ovarian
You
cancer.
need to just think about male or female, right or left. If you
Yes.
right, you have more options. If you left, you have less option. If you
Yes,
female, you
exactly.
have more option. If you male, you have less option.
Yes,
Just
exactly.
the thing. And one
طب in
important
left,
thing, yes,
And lip,
tuberculoma, lymphoma, ectopic kidney.
exactly.
In case of the female ovarian cyst, and
The
also
same,
colonic
but
carcinoma, like
remove the cecal and appendix. It
appendicular,
will be colon.
vesical, carcinoid, like that. You can even
Yeah.
carcinoid tumor can happen in the right electroshock. Crohn's disease
Anywhere.
you can found. Crohn's disease you can found in the right electroshock.
Yeah,
And
here you cannot
one,
mention Crohn's in the left.
no, right. I'm telling about the right.
Yeah. I mean, this is the difference. She's
Yes,
asking
yes,
what the
yes,
difference
exactly,
between right
exactly.
and left. So you remove the Crohn's because the Crohn's
Yes, yes,
mainly in the small bowel. Now
yes.
you have colon, so you can mention any disease in the colon, cancer colon, tuberculoma, mass, even
Diverticulosis.
diverticulosis. Okay, yes, and mention the female. If you're stuck and you have male, tell him about female. What's the problem? If I have female, I will think about ovarian mass. But you have to give him two differential before saying in female, like cancer colon or tuberculoma. And of course, our case. Don't forget our case. Don't mention this without mentioning the ectopic kidney. Sorry, the transplanted kidney.
transplanted kidney وectopic kidney in both sides.
Okay.
الاتنين.
So please mention
وcolon.
them. Yeah, and colon. So mention it while you are putting the differential. Don't forget it.
Okay.
And
Okay.
actually, examiner question depends upon your response.
Yes,
And
exactly.
I'm thinking that examiner, if you ask more, that is a good thing. Like he
Mhm.
want to make you pass. That's why
Yes.
he want to something invent from you.
Yes.
So as 4 minutes, so if you not something confusing and unable to answer, so better to say, sorry, sir, I cannot remember something, a polite way. So examiner, can you ask the next question? Because if you cannot diagnose it, or if you cannot do proper investigation, so examiner maybe will not go for management. So it depends upon like finding, then what are the investigation, what are the management, what are the complications.
Yes.
When you responding well, that time examiner will ask next question. But if
Yeah.
you are obstructed, maybe examiner with depression phase, he will not go for other.
Yeah, he will wait for
So
you. No problem. Yeah.
yes,
You're right. And please
exactly.
put your answer in systematic way. general investigation, specific investigation, bedside investigation, non-invasive test, invasive test. Believe me, it will give you good mark because he knows that you are a good doctor and you are a regular and you are organized doctor in your investigation. In even the management plan, non-pharmacological, pharmacological, multidisciplinary team approach. Here you have a lot of team you will involve in this patient, so you can take 30-second mentioning the teams only, and it's safe answer. You have to bring the nephrology, you have to call the hematology, you have to call for infectious disease, uh, cancer, oncology.
Oncology.
Yes, exactly. Specialized nurse and diabetes, for example, if the patient still recurrence of the disease, so you can call for rheumatology. You can create a lot of answers for one question, which can give you good mark. Still, you didn't talk about the specific management. Either the cause is rejection, so you will not talk about the possibility of giving medication for the rejection. You are not aware about all this medication, right? Rather than asking you also about the possible side effects of the medication, if you are not aware about all of them, but you have at least
Don't forget.
what? Sorry.
Especially transplanted team is by name.
Yes, perfect. Thank you, Dr. Rashid. This is the most important team ever in any renal, any transplant, not only renal, lung transplant, cardiac transplant, pancreas transplant team should be called once the patient admitted to the hospital. Even the patient himself has the number team, the contact number or the team of the contact number of the team. They can give you by himself the number. Talk to my doctor because these patients are precious for the transplant team. They are not many patients. Maybe few patients had this transplant, and you want to make it success for him. They don't want the patient die after a couple of months. They want to have assure about months or years life expectancy, and otherwise, why they did this transplant? So please mention the transplant as Dr. Rashid remind us.
I
I
just
want.
want to add
Yeah.
point.
Yeah.
Any
Sure.
transplant case, any
Mhm.
transplanted case, any like liver, lung,
Mhm.
kidney transplant, any transplanted case, we have to tell four important things that your DD, first DD as a transplant, how you think this is a transplant, like there is a clamshell incision for lung, for liver, Mercedes Benz. Here you can
Yeah.
find joystick or writing exposure oblique. And what about the transplant organ? Is it like what about consistency, like firm, hard, tender, painful,
Yeah. You
not
have to.
painful,
Yes.
any? So you have to tell what you think transplant, how you think this is a transplant, and what about its now structural structural finding. Then what about that any complication, like common complication in the liver case? If you found there is a like ascites, jaundice, or patient encephalopathy, of course there is a feature of that
Yeah.
decompensated liver disease or
Decompensation
liver
or compensation. Exactly. Yeah.
failure of the failure. If you found even cardiac transplant, even lung transplant, if you found broncho, what is that? Broncho obliterance,
Yeah. Bronchiolitis
bronchiolitis
obliterans.
obliterans.
Yes.
Yes, if you found that, if you found feature of that fluid overload, of course that means pulmonally, that means lung is not properly function. Same like for valve transplantation, if you found that feature of the arrhythmia, heart failure, or pulmonary hypertension, that means and that metallic click you are not audible enough. That means it's and also regurgitation murmur you found. That means valve is not working properly. Same like renal. If you found fluid overload, if you found patient looks like drowsy, then patient is scratching mark, eulomic feature, flapping tumor, that means it's not working properly. So you have to tell what is that main diagnosis, how it's properly working, and is it any complication, and what
Yes.
about the immunosuppressive therapy. You have to mention, of course, even you get or not get, you have to tell. Same like cardiac disease. You get
Yeah.
infective endocarditis or not get, but you have to mention. I could not appreciate feature of the infective endocarditis. I could appreciate. Same thing. Something you have to mention as the negative.
Yeah. Thank you, Dr. Tanvir, for explanation.
And one practical
Yeah.
things I tell, this is not related with the exam, that if you found in the practically, if you found there is any fistula case, don't do measure the blood pressure in that hand, and don't tell to do that IV cannula near to that fistula, because this is contraindicated. This is not for exam purpose, just as a general.
Yeah, for practical. Yes.
For practical, yes.
Yes.
Thank
Thank
you.
you, Dr. Veer. I'll try to read the comment quickly from the first case, shifting dullness. Yes, Dr. Rashid, Kala Azar, amyloidosis. Is there way any sign of rheumatoid arthritis on the hand examination other than nodes at the elbow? Yes, of course. You have a lot of finding for this rheumatoid arthritis, the deformity, the effusion, the warmness, or the Guttern papule. You have a lot of dermatomyositis association, carpal tunnel syndrome. If you have, don't forget that carpal tunnel. It's important. So you have a lot of finding in rheumatoid or peripheral signs of rheumatoid in the hand.
I mean,
Renal
in this
phenomena
case, in this case,
in the chest.
in this case, there was any finding.
Okay. Sorry, Dr. Rashid. Okay, I also make it in general. It was only elbow nodule.
Mm.
Okay, could be maybe
It's
trochlear.
very hard like this.
Sorry.
And very hard to only elbow nodule and then you can
Yeah,
suspect
but at
something.
least it's one of the clues.
No, it should be lazim.
Yeah, you can correlate it, but better than saying other causes. Okay, deposition, leishmaniasis. Dr. Ala asked for, please repeat. Yeah, I already repeat. I think he asked for the abdominal examination steps. Ask for cuff for hernia orifice. Yes, when you stand at the bed, at the end of the bed, ask the patient to take breathe in, deep breath in and out, and ask him to cough. It will make the hernia more obvious for you. Okay, liver span percussion on lower right chest. Yes.
البريسنج في الchest أحسن ولا also في الabdomen؟
Sorry.
Breathing to take deep breath and out. I think with chest when
Chest
you
and
are
abdomen. And abdomen, because if you have hernia or distension, you will see it.
أيوه طيب.
Movement with the respiration. Okay, abdomen, no need to in details. General, this is division of complication. At least do percussion. Yeah, I agree. You have to do percussion if you have some distension to rule out any shifting dullness. Skin cancer, yes. What the
Detail, I mean, he went in detail in pulse. No need in abdomen in details.
It's not important.
Yes.
Compared to
So,
the fistula itself examination, the needle
yes.
marking, the percussion, and the auscultation. Palpation, sorry, for Berwi, and auscultation, sorry, percussion, palpation for the thrill, percussion, auscultation for Berwi.
Yeah, it's only enough.
Exactly. The cause of tender graft, exactly, either rejection or infection. Dr. Rashid, last comment, differential of renal angle mass can be raised by examiner. What the renal angle you mean? Renal angle, the renal area you mean?
Yeah, yes, renal area. If there is swelling there, or
Yeah,
found
good.
lump there.
Perfect. So the ballotmit kidney, right? Is it bulbable kidneys you mean? So polycystic kidney?
Yes, zero organomegaly يعني. It could be
Yeah.
polycystic kidney.
So
Yes,
polycystic kidney cyst.
yes, hydronephrosis. They like this one.
Yeah,
Yes.
pyelonephritis also.
Hydronephrosis and polycystic renal mass, renal carcinoma.
Renal carcinoma, yes. So infection, cancer, or water, hydronephrosis. Cancer,
That
infection.
is the DD of polycystic
Amyloidosis.
kidney disease. If there is a loin mass, renal mass, the DD, it will not coming usually with the renal transplant.
What is
It's
it?
like if you're thinking that when you get polycystic kidney disease, that time examiner can ask, what are the DD of that mass? That time you can tell polycystic kidney disease, simple
Yes.
cyst, tuberous sclerosis, hydronephrosis, renal cell carcinoma. So it's
Yeah.
coming usually with mass in the loin or ballotable mass. It's not coming with the renal transplant. So please be careful with the renal transplant mass and with the polycystic mass. These are completely different actually. So
Yeah.
renal transplant, when your DD should be one way, and when you are ballotable kidney, that is another type of DD.
Yes. Okay, the last question. When they are doing nephrectomy, in for renal transplant when they are removing the kidney, or what the indication for nephrectomy? Anyone?
Nephrectomy is done usually
Answer.
when autosomal polycystic kidney disease it makes troublesome. I mean, it causes recurrent infection, recurrent stone formation, chance of the
Yes.
rupture.
Okay.
That time you have some indicated point. There is a chance of the rupture, recurrent infection,
So
recurrent
yeah,
stone formation, make the
yeah,
life worse. So
yeah.
that time you
Intractable.
have to,
Yeah, intolerable pain or
yes.
wound or
But
infection
main
or
thing will
rupture.
be chance of the rupture. You have to
Okay.
tell the important things are first,
Okay.
because
The
I think
important.
rupture is more important than the pain. Recurrent
Okay.
stone, recurrent infection, chance of the
And pain
rupture.
bar is very important
So
because sometimes there is intractable pain when the
Pain.
cyst is
Intractable pain.
yes, yes,
Exactly.
exactly.
And the most
yes,
Yes.
important, more than
hemorrhage
those,
also.
the more important, more than those, spacing for the new kidney. Sometimes because of the large kidney, you don't have space because of the large kidney to put a new kidney. So they are doing nephrectomy just for spacing, make a space for the new transplanted kidney. Okay, it's important to mention this. So it's intractable pain or hematuria or stone or rupture.
Malignancy also.
Sorry,
Malignancy. Malignancy.
malignancy. Yes, of course. Yes. Okay, thank you. I think it's very fatty session today. We had a discussion about all splenomegaly and also for renal transplant, hyperacute rejection. Yes, it happens within minutes on table. Maybe patient is still in the OR, hyperacute, minutes to hours, because of rejection or some leukocytic reaction like that.
HLA mismatch.
Okay, HLA, HLA mismatching. Yeah, this is the
Okay,
answer.
one thing is Dr. Marwa.
Okay.
She did collapsing pulse. For what purpose actually?
Yeah,
In the
I think
abdomen
it
case,
will. Yeah, it will waste time, Dr. Mara. It's
it
not
will waste time.
important.
It will make a negative marking. That
Yeah,
examiner will
Yes.
write a note. She did collapsing pulse because it's
let's.
I think when you go out of the frame, you
Yeah,
have to travel for out of the
yeah.
out of the frame.
Focus
Okay,
on the
only
two.
on the cardiac بس يعني.
Yes, exactly.
Collapsing
In
the
the
only in
cardiac.
cardiac بس.
Exactly. Exactly. In the cardiac. Yes.
Okay.
Okay. Okay. Big thank to Dr. Tanvir and Dr. Marwa. Really, it was a nice session and very informative one. Thank you for preparing the cases, Dr. Marwa and Dr. Tanvir. I hope others. It's easy, even without records, without videos, without imagination, without picture. Just we are imagining together and we have discussed about. We are memorizing the step, how to do the steps. Please, anyone, don't hesitate to prepare and to practice this session. I add this session, wallahi, for you. It's really giving you confidence. And the discussion, believe me, you'll remember every point we discussed together. And these are the questions they are asking. It's not something from Marikh. They will ask the same question: how to approach, how to investigate, how to manage, about the differential diagnosis. And what we are discussing commonly, and hopefully it will come in the exam. Any comment or question before ending the session?
Okay, thank you, Dr. Wasim. Even after
Awesome. Thank you.
passing, you
Thank
are
you.
doing the session.
Thank you.
That is your great effort.
Thank you, Dr.
And
Tanvir.
actually, I was not prepared about the cases because I think maybe 5 minutes before you ask what case
No
you want
worries.
to
No
do.
worries.
So I
Don't
said
worry.
any. No, no, I'm telling any randomly any system
Yes, yes.
because like if you want to go any system wise, so I think better to write when you are making announcement that we want to do abdomen or respiratory like that.
Yeah,
But I
hopefully.
was not totally prepared. When you said me, I immediately thinking I will give a renal case like that.
Thank you. Thank you, Dr.
And the
Tanvir.
good thing is, Dr. Basim, to rebus the head of the bed on deep validation very important. So it's easy to can get organomegaly with inspiration by
Yes.
gravity.
Yeah.
But if it is still flat, you can miss or you can go over it for organomegaly. So you have to raise the head of the bed again.
After or before, you mean?
No, after we want to for deep validation, I mean.
Uh-huh.
You put flat for superficial. When you finish superficial, you are going for deep, you have to raise again.
No, no, no. We are continuing at the same.
If you're repeatedly raising, repeatedly making flatting, it will
No, the deep
worse
validation
for
should be
your
raised, I think so.
No, no, no. We are
Because
doing
if
no
you
flat position. Why you
flat,
raised the
flat.
flat
Yes.
position?
Take
because
care.
you can get the organomegaly easily.
You will get it even with the respiration with flat.
Sure.
Yes,
Yes,
yes.
sure, sure. Yes, sure.
Only for cuffing reflex, you can make a little propped up. Otherwise, you can do everything like in
Yes,
the flat
yes, yes.
position. Because when you
I was
repeatedly
thinking when you
making
put
flat,
مثلا 45-degree,
No, no, no.
chest will be raised here
no,
and
no, for
then
abdomen,
No, no,
not
no.
for 45.
No, no.
If you repeatedly doing
45
changing, it
only.
will,
Yeah, 45
yes,
only for
cardiac and
raised
respiratory.
GVP and cardiac and
Cardiac
respiratory.
respiratory issue.
Yes,
I
exactly.
need only deep
20,
validation. I need deep validation.
45 degrees just make abdominal muscle tense. You can feel well.
Yes,
But
exactly.
flat, you make your abdominal muscle lax.
Exactly. This step, by the way, this step, if you miss it while doing abdomen examination, believe me, they might fail you. If you examine the abdomen while semi-sitting or sitting, it's like a fatal mistake for
No,
for the
I
case.
mean only deep
Yes, I know.
validation.
Even no, 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 it's not. Believe me, as Dr. Marwa said, the patient will be tense and the muscle will be stretched. You cannot feel anything. The best position to be relaxed, the abdomen relaxed, is in the supine, flat. Okay.
Okay.
If you want to examine before that, you can do the raise GVP. You will press over the liver and notice the raise GP or congested neck veins over the sternum angle. Apart from that, you cannot do anything else in the semi-sitting. Okay. Any other comment or question? Very good idea to short case. Yes, I believe it will help all of us because we discuss a lot of topics in long and communication. And also there is some marks can fly in the short cases. I don't want anyone to have failed because of this short stations. That's why I created this session.
And one important thing is if you catch the diagnosis, mostly you will not fail. Because when you catch the diagnosis, your investigation, your treatment, all are going to right way. But if
Yes.
you cannot catch the diagnosis, all the thing will go in the wrong way.
Yes, exactly.
So that time it's most of
They
the
will
chance
go
it's
with
a
you till
matter
the
of
end.
fail.
Yeah,
Yes,
it's like toxic examiner. He will go with you until the end,
yes, yes, exactly.
the
But
wrong
most
way.
of the examiner actually, what I know that most of the examiner trying
Un-
to overcome
Unfortunately,
you. They are
yes.
giving some clues that you
Oh yeah,
overcome.
this is
But
fortunately they are correcting you. Yes, fortunately.
no, not correcting. They are giving
Really?
clue. They are
Clue,
giving
yes.
clue.
So if
Yes,
you
not
Prompting.
correcting. That
so it's not
they will
corrected,
asking, do you
at
think
least
any other thing? Do you
yes,
think
I
any other thing
this is
like that?
good thing
Yeah,
also. There
Bronx.
That is a good thing.
yeah, good
This is a
thing.
benign matter
Uh,
of benign
exactly.
examiner.
Benign behavior. I know some of them they will be laughing in sarcastic way like what he's saying and he will give you very bad mark. So
But
to give
another
you
one thing is,
yeah.
yes, and another one thing is, sometimes we are thinking, oh, I did good, but later you found
Yes,
that is
exactly. He
not
will
good number.
smile, he will be
But
happy.
you think that is a not good, but maybe you will
Exactly.
get good number. Like my nervous system, I got 17 out of 20 in my last attempt.
Mm.
But I feel that I did not do actually well. But
Yeah,
something I in the end I make a some important clue. I
that's factor.
like
Yeah, yeah.
invented. So immediately my impression changed. That's why I
Uh-huh.
get actually 17. So it depends upon that
Yeah,
until the last what impression you made.
yes, exactly. So the examiner wish and your luck,
Yes,
hopefully.
exactly. And
Yes.
need to do actually
So yeah, Allah
practically these
subhanahu
things.
wa ta'ala.
Sorry?
We are talking that we will do this, but for
Yeah,
clinical
exactly.
examination, actually need to do practical either your home,
Yes, yes,
your
yes.
family
In
member, or in
family
the
or
hospital,
exactly. Any patient, any
like that.
friend. Yeah, any
You
friend.
have to fluent like that
Yes,
to
exactly.
examine.
Yes.
Okay, thank you, Dr. Basim.
Thank you, Dr. Tanvir. Thank you, everyone. Thank you, Dr. Marwa, Dr. Rashid, and everyone commented. I hope I read all the comment and we cover this topic. Hopefully, next session will be for either cardiovascular or chest. Anyone ready for them? Please message me. It would be on Monday next week, inshallah. Yeah, also, this is the weekend. Sorry. We have to wish happy weekend for all of you. See you after tomorrow, inshallah. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
وعليكم السلام ورحمة الله وبركاته.